So just an FYI, don't say anything untoward. We're recording. Sage advice.
All right, I'm going to go ahead and respect everybody else's time here. So we'll move forward, trying to be able to follow chat. So I apologize that the screen just went out. Good morning. So this is March case reviews. Thank you guys for your time. As always, this information is confidential and privileged. It is protected under the HIPAA Act, and that distribution discussing this in a identifiable, the cases in an identifiable way are strictly prohibited. All right, so moving forward with case one, this is of a 34-year-old male, reportedly found in the backyard. The call was dispatched as unconscious. PPE usage was appropriate for any parts of this pandemic. The patient was found to be alert. His airway was open and he was protecting it. He had a pulse that was present. It was noticeable that he was jaundiced in appearance. He was otherwise warm and dry, and there was no evidence of active bleeding. Vital signs were obtained immediately after patient contact with a heart rate of 108, a blood pressure of 112/57 with a MAP of 75, a respiratory rate of 18, GCS of 15, and normal sats of 98% on room air. They checked his blood glucose, which was 93 milligrams per deciliter, and he was estimated to be about 80 kilos. His past medical history was of alcohol abuse, and he had reported no known drug allergies, and the family that were on scene had stated that the patient was complaining of shortness of breath and leg swelling. He had an extensive alcohol abuse history, and that even on that day, he had consumed 6 beers. So this was about 5 o'clock in the afternoon or evening. Vital signs that it just previously reported to you. In addition, the patient relayed a couple additional information. He said that he was having bilateral lower extremity swelling for about a week, and then he's been short of breath for the last 3 days. He states that he was feeling dizzy when he stood up. He did admit to marijuana use, and the physical exam was most notable for 3+ pitting edema to his bilateral lower legs. 12 minutes after patient contact, a 12 lead was obtained. It was not uploaded, so I can't show it to you guys. They initiated transport at 16 minutes, obtained another set of vital signs after initiation of transport. Now heart rate improved down from previously 108 to 99. Blood pressure is 100/40. GCS, respiratory 18. GCS is normal, and his sats are normal. One of the things that I'll remind you guys is that oftentimes abnormal vital signs are related to the hospital as normal. So clearly his vital signs are not normal. And then the other common thing that I think gets said often is they're stable. This patient, although his heart rate is improved, his blood pressure is declining. So I wouldn't call this stable, and you need 2 sets of vital signs to determine stable. So another set of vital signs were obtained, and he's kind of maybe a little bit more tachycardic if you count 1 beat. So it's technically at the abnormal value or abnormal range. His blood pressure now is 110 by palp, respiratory rate of 22, GCS still 15, and still 100% on room air. An IV was attempted, an IV was attempted and missed. So this was his second IV attempt or second IV placement. And then transport to the hospital occurred at 30, or transport arrival at the hospital occurred at 39 minutes. So in reviewing just the pre-hospital side of things, great job getting a 12 lead. Ideally, with a syncopal episode, we would want to get a 12 lead within 10 minutes of patient contact because of the concern for a possible STEMI. These guys did a great job of getting serial vital signs. They wanted 2 IVs, but the second IV was unsuccessful. And they documented a chest, abdomen, and extremity exam. Where we could do better is that upload a 12 lead if it's been done. Times or estimates, that was in their documentation. We assume that the times are the best estimate of what time they occurred. So putting a little blurb in your narrative saying that times or estimates are not going to be helpful in protecting you against ownership of your vital signs or your treatment. And then although the patient had complained of shortness of breath and had lower extremity edema, no auscultation of the lungs were either performed or documented. And then this gentleman, given the alcohol abuse history and jaundice, puts you at higher consideration for liver disease. So evaluation of mucosal membranes would be advantageous, especially because, as we'll talk about later, GI bleed is a high probability for the differential in a syncopal alcoholic. So upon arrival to the emergency room, he was unresponsive. Apparently, he became less responsive en route, but they did not upgrade him to a higher level of transport. They RSI'd him, and they placed an NG tube, and he had massive hematemesis. His initial hemoglobin came back as 1.6 milligrams per deciliter, or grams per deciliter, when normal range is 14 to 17.5. So profoundly anemic, profound loss of blood, likely GI bleed given his past medical history. And mind you, this is, I believe it was a 34-year-old gentleman, so a young person in general. A massive transfusion protocol was initiated, and he received multiple units of blood. He was admitted to the hospital at Legacy Salmon Creek. Actually, I'll rephrase that. He had an elevated troponin at the emergency room, and in consultation with cardiology, they felt that he would be best served to be transferred to a catheter capable hospital. So they transferred him. No, this is a different one. I apologize. So he's admitted to the ICU, and he underwent an endoscopic scope. They found bleeding varices, most of which were banded, but because of his continued bleeding, he was transferred to a manual where he underwent a TIPS procedure. Unfortunately, he left AMA on hospital day number 6, and since the time that he was discharged and completing this case review, he was admitted again for hemorrhagic shock and GI bleed, requiring additional banding and a TIPS revision, and he was also had an elevated ammonia level in the low 200s. He was not, his initial hemoglobin on the second visit for his GI bleed and shock was not as low as his first visit that we are presenting here. So this was a case that was brought up to evaluate the sequela of alcohol cirrhosis and what to be mindful of, and had a high index of suspicion for badness. So alcoholic cirrhosis, it's associated with excessive continued alcohol consumption. The liver is the primary site for for ethanol metabolism. So it tends to be the area that we see fail first, or the first evidence that there's a problem, and that is related to the spectrum of alcohol liver disease. So a normal liver is indicated here in the upper left-hand corner. As you continue to drink, you develop steatosis, or alcohol fatty liver, where fat deposition is more prevalent. If you stopped drinking, which is indicated by the green arrow, you could go back to normal liver. But if you continue to drink, you can either go to steatose hepatitis or alcohol hepatitis, or you could move towards cirrhosis. So more inflammation in addition to fat deposition. At this point, you can stop drinking and return back and reverse this condition. But if you continue to drink, you move on to cirrhosis, which is going to be significant scarring and fibrotic changes, and that you have, or you could go on to hepatocellular carcinoma or cancer of your liver. So either from your alcohol hepatitis straight to hepatocellular or going to cirrhosis and potential progression to hepatocellular carcinoma. The vast majority, yes, go ahead.
Yeah, I can't get.
Sorry.
There we go. I couldn't get my mic on. Not everybody knows what steatosis is.
Fatty liver, which is fat deposition.
Okay, good.
Yeah. So the significant morbidity and mortality is related to the portal hypertension that develops from the compensation of the blood flow from the liver. And then there's compensated and decompensated cirrhosis. Compensated cirrhosis is that they don't necessarily manifest the external findings, but they have either abnormal lab values or imaging that suggests that they have cirrhosis. And decompensated cirrhosis is when they develop the significant sequela of cirrhosis. So that would be ascites or the fluid in the abdomen or third spacing. Jaundice, the yellow discoloration of the external exam. You might, I would say that the most sensitive area for me to identify jaundice, and I don't know if that bodes in the literature, is the sclera. So that's a place where you should be able to identify even subtle jaundice. And then if it's more profound, you'll see along the skin the yellow discoloration, but obviously the sclera will also be markedly more jaundice as well. You may see that the patient is altered, and that's for increased ammonia levels as the liver is unable to metabolize the ammonia, in variceal bleeds due to increased portal pressures causing the epigastric vessels to enlarge and become inflamed, and then potentially cancer, hepatocellular carcinoma. So the organs affected, I think that, it's probably pretty common for us to say, well, you're going to have a protuberant abdomen and they may be jaundice. I think, though, it's a good reminder that although the liver seems to be the most talked about abnormality on the assessment of a cirrhotic patient, all of the organ systems are affected by the alcohol consumption. So the GI effects, as mentioned earlier, is the portal hypertension leading to enlargement of the liver and the spleen, as well as ascites. You may notice that there may be some prominent periumbilical abdominal veins, so kind of like that, the belly button becoming protuberant as well, and then you can see some blood vessels starting to be identifiable on the abdominal exam. They have an increased risk for esophageal varices. They have an increased risk for infection of the fluid in their abdomen or spontaneous bacterial peritonitis. They also, because of their alcohol consumption, are at risk for chronic pancreatitis, which has its own gamut of issues associated with that. These patients are often anemic in regards to hematological organ system. They're oftentimes anemic because of nutritional deficiencies, but they can also be anemic from hemolytic anemia. They have impaired coagulation, easy bleeding, and as for the renal manifestations, due to the liver disease, they are at risk for a condition called hepatorenal syndrome, where their systemic blood pressure is often low and the blood vessels in their renal system are vasoconstricted, so they have poor perfusion to their kidneys. That could lead to renal failure, acute or chronic. And then pulmonary-wise, they are at risk of a condition called hepatopulmonary syndrome, where this is related to portal pulmonary hypertension and decreased oxygenation, potentially from obstructive from their ascites. Skin manifestation would include spider nevi, abnormal blood vessels in the superficial layer of their exam. And then as for endocrine, they're at higher risk for hypogonadism as well as gynecomastia, which hypogonadism, small sexual organs, and gynecomastia, for those that are not familiar, these are going to be skin tissue change to their breasts to make them more feminization due to higher estrogen levels. And then lastly, but not least, is neurological manifestations such as hepatic encephalopathy from significantly elevated ammonia levels. They can be anywhere from confused to obtunded. So another point is tachycardia should not be taken lightly in these patients that are manifesting evidence of cirrhosis, and that we have lots of organ systems that can be involved in a good exam, not just what you can see externally without any manipulation of their body would be appropriate. So in this case, an assessment of the mucous membranes or the conjunctiva could give you a hint that this patient is actually quite anemic, or you could be asking this patient, are you having any blood bleeding? More likely, but not isolated, but more likely to be upper GI bleed, but also ask about lower bleeding. All right, so our protocol in regards to this patient would really be most focused on shock and management of shock. So for the hypovolemic patient, if there's any external bleeding, control it. One of the things, this is hospital-wise, that could be done is a Minnesota tube or a Blakemore tube. It looks pretty prehistoric when it's placed, but that would be an effort to control internal bleeding at the esophageal varices. Giving up to 2 liters of isotonic fluid as rapidly as possible, maintaining a systolic blood pressure above 100 or a MAP of 65. From recent knowledge, I would really focus on assessing and guiding your therapy based on MAP because of the way that our monitors are set up to present blood pressures, and then watching for signs of overfluid resuscitation such as distended neck veins, pulmonary rales. And then mental status is really important. Obviously, these patients, if their ammonia levels are high, they may never have normal mentation, although they've been appropriately resuscitated. So recognizing that as you have competing things that could be affecting their mental status. And then this is just the remainder of the shock protocol. Any questions, concerns, discussion you guys would like to discuss on this case? Don't forget two IVs above the diaphragm. Ideally, this particular crew attempted 2 IVs, and that tachycardia may be your first sign, as well as a mental status. And document the amount of fluid you've given and at what time. All right. Case 2. Let me just double check there's no comments. No. All right, so case 2 is of a 31-year-old MVC. The patient's chief complaint was right wrist pain. PPE usage was appropriate. The patient was awake. His airway was open and protecting. His skin exam or his circulatory exam was that he was pink, warm, and dry, and there was no evidence of active hemorrhage. Vital signs by the transporting crew were not documented until after 10 minutes, but they did document the fire department's vital signs, which was a heart rate of 136, blood pressure of 172/112, respiratory rate of 20, and a GCS of 15. This patient had no complaints of past medical history or meds, but he was allergic to penicillin. And the story is that this is a single vehicle accident. It struck a tree head on at a high rate of speed. It rolled over, but the patient was restrained. He was not ejected. There was evidence of starring of the windshield, and that there was significant intrusion into the passenger front compartment, obliterating that passenger side completely, and that extrication was the issue because he was still pinned. So this occurred at midnight 21. They activated or they documented as a full trauma at that time, as well as a prolonged extrication. They initiated spinal precautions while they were attempting to get him out of the vehicle. And at 11 minutes, assuming that this is the time that that they were able to get him out of the vehicle, as there's no additional vital signs or intervention, he was transported. An IV was placed and he was given 50 cc's of fluids, or 50 mLs. At 12 minutes, he had a second set of vital signs: heart rate now 113, blood pressure 134/63, respiratory rate is 16, GCS of 15, and SATs of 96%. At 16 minutes, and I believe that the actual time for extrication was documented as 75 minutes. Anybody who is knowledgeable or was on that call, feel free to put it in the chat if it was less or more. So first 12 lead shows irregular rhythm, wide complex. This is, again, a younger patient. I believe I said like 30s. And he had said no past medical history. Our life pack auto interpreted it as atrial flutter at a heart rate of 120 with a left bundle branch block.
Which it is not.
Yeah. So I find, well, I don't think this particular crew read it as what LifePack read it. They obviously read it differently, but I have found that we tend to, at least the ones I've come into contact with, is go off of the LifePack interpretation over your own potential, unless you interpret it exactly the same. But I think that be careful about just looking at the monitor's interpretation, as it is not always accurate, as demonstrated here and in other cases. So they get another set of vital signs. The patient's still tachycardic at 116. Blood pressure now is 144/68. Respiratory rate 16, and he still has a GCS of 15. They interpreted that 12 lead as concerning for wide complex in conjunction with the fact that this was trauma and he was pinned. I think he was pinned by his ankle. They initiated hyperkalemia management, assuming that this was related to traumatic rhabdo. So they gave him 5 milligrams of albuterol. They gave him 2 grams of calcium gluconate. They gave him, after another set of vital signs, still tachycardic, still hypertensive, normal respiratory effort, normal neurological exam. They gave him another 5 milligrams of albuterol, and they gave him a gram of calcium gluconate. And I don't remember the time frame. So that one, 43 and 59. So they repeated the 12 lead approximately 16 minutes after the first one. I didn't put this in the next section on the QA review, but this is a good reminder as I'm going over, is that if you're really concerned about hyperkalemia, the first drug that should be administered to the patient should be calcium. I find it hard to believe that albuterol is easier to put together and administer over calcium or anything that is given in the IV, just because of the fact that you have to get a neb and put it together and put the med in and then put it back together and give it to the patient. So I believe, in my experience, anything IV is faster than another contraption, unless your IV wasn't previously established, which this patient's was. So calcium would be the first agent, and that's cardioprotective to ensure that the rhythm doesn't degenerate. All other agents, if you're treating for hyperkalemia, would be working to push potassium out of the vascular and out of the systemic and into intracellular. So calcium should be the first agent given.
And then if you know, I have other things to say about this one, but
Yes.
as you know, but the other thing is, if you're really going to go down this is hyperkalemia protocol, trip, you also need to follow the rules. And besides calcium, bicarbonate is indicated.
Yep.
But that's secondary to calcium, and the albuterol can be albuterol. The nice thing about albuterol is that the partner, the EMT partner, can put together the med neb and get that going if you have enough hands on the patient already.
Absolutely, good point. For sure, is that follow if you're going to run down, and I think that is going to be displayed in another case, is that if you're going to pull the trigger and decide to treat something, make sure that you are adequately, completely treating that condition and not missing anything as part of that management.
Right.
So in this patient, 2 lines were obtained due to concern for a full trauma. Documentation that the scene was extended secondary to, I already have it, but anyways, documentation due to extended scene time, 12 lead obtainment due to concern for tachycardia, but also because of the concern for ischemic injury to the patient due to entrapment. And then an early trauma activation. We appreciate if you guys can let us know. I know that there's competing issues with scene management and patient care, but when you guys know what's going on and letting us know so that we can get the necessary people, especially if they're not physically in the hospital, mobilized. And then the bad, I would add complete management of hyperkalemia, but also this is a patient that, do you treat for permissive hypotension and trauma, or do you treat for rhabdo and traumatic rhabdo, where there's competing issues with that? One is IV fluids only if their mental status is affected and or their systolic blood pressure is low, versus rhabdo is the mainstay is hydration, hydration, hydration to ensure not developing renal failure. So there's competing issues going on with this patient and trying to decide what the most appropriate management is. And in these cases, when you're not sure, you can always contact online medical control. You can always be supportive, but if you're going down the management of hyperkalemia as your major issue here and your vital signs don't suggest that the patient is hemorrhaging internally, pressures are not declining and he stays tachycardic, then you could also build your case of managing one way or the other. So either call medical control for advice or guidance, or use your serial vital signs assessment and physical exam to determine what your goal of care should be. So this patient was transported to Emmanuel because there was a trauma divert status at Peace Health. At the hospital, I pretty much only have the discharge information. But anyways, he was identified to have new heart failure. They thought it was related to alcohol abuse. His troponin was mildly elevated, but not rising, so they don't think that he was having a in-STEMI. As for his workup for the injuries from his car accident, the only injury he sustained was a right radial fracture, which was the complaint that he had indicated on scene. He was identified to have the first time identification of diabetes. And then he also suffered an injury to his retina, traumatic retinal injury, which they call commotio retinae. So this case was brought up as identifying rhabdo, what's going on, and the appropriate management of rhabdo. So rhabdomyolysis is a rapid dissolution or extravasation of damaged skeletal muscles. There are multiple reasons or possible indications or insults that can lead to rhabdo. One of the more common ones is trauma. And in this case, that's the one we are going to be focusing on. But medications can cause it, lack of movement. So like somebody who is found down and hasn't been able to get up is another one, renal failure. So it can go, there's multiple potential promoting factors. So it's usually caused by blunt or crush injuries in the traumatic cases. The symptom, so this picture on the right is kind of a little bit of an algorithm of how it gets how it occurs. The box on the upper left is all of the potential causes of rhabdo. The box on the right is the one that we want to focus on, because one of the promoting factors for rhabdo is trauma in that box on the right, which is where you're going to kind of focus on. So there's a rupture to the skeletal, an injury or damage to the muscle fibers, which affects the sodium-potassium channel. Normally, the sodium is outside the cell, potassium's inside the cell. When these cells are injured, they lead to disarray of that balance. So potassium goes outside the cell, sodium comes in, sodium brings water with it, causing further injury to those cells. It affects the calcium channel, which leads to higher levels of calcium externally. And then this goes on to leading to cell death. It affects the mitochondrial energy formation, so less ATP is formed, which goes on to work as a vicious cycle to lead to rhabdomyolysis or myolysis. So the patient, they say the classic triad is myalgias, weakness, and tea-colored urine, but only 10% of the patients will actually have that triad. So it's going to be index of suspicion, and it's going to be the luxury we have in the hospital is checking a blood test called CK, but also looking at where we think, especially in our setting, where the risk is that they may have an injury to the muscle. So that would be with these trauma patients, assessing for swelling, pallor, pulselessness, pain out of proportion, stuff like that. These, again, the risk factors are indicated on these boxes up on the top of this display. And the management, the mainstay of treatment for rhabdomyolysis is hydration, adequate aggressive fluid resuscitation to prevent renal failure and allow for excretion of the muscle fibers, and also to dilute the extravasation of the injured cell content. There's some thought that there might be benefit to alkalinization of the urine, which is giving bicarb, but the studies don't really bode out. So it really is hydration. And then looking for electrolyte abnormalities in all cases would be really making sure that potassium is normal and treating elevated potassium situations. And then these patients may go on to get a fasciotomy. So hydration, hydration, hydration. Watch for signs of rhabdo or hyperkalemia. So when I search rhabdo in our protocols, it comes up in the PEA and asystole cardiac arrest algorithm for H's and T's, and then it comes up in this algorithm or this protocol for IV fluids. So besides recognizing that it may be a contributor to the cardiac arrest situation, it also should be considered that you do not give lactated ringers to patients that are at risk for hyperkalemia, which would include end-stage renal disease, crush injuries, and rhabdomyolysis.
Tell them why.
Increased potassium administration in the lactated ringers.
Correct.
So in management of hyperkalemia, as Dr. Whitber had already pointed out, you are going to get an IV, you're going to give calcium. In discussion with a recent crew, they had told me calcium first because it's in that order, which is helpful if you memorize that, but it'd be more helpful to know why it's first. And then bicarb and albuterol would be the other agents used to treat hyperkalemia, and get them moving sooner than later to the hospital. Any questions, concerns, discussion?
I have some comments, as you probably guessed.
Yeah, do you want me, do you want me to go back to any particular slide or?
Well, you might, yeah, go back to the slide with the EKG, with the 12.
Yeah,
But in the meantime, I will discuss, oh, okay, I mean, I think it's great that they thought about the potential for crush injury, or for rhabdomyolysis. However, they then needed to evaluate the patient as to whether this is likely. This patient was entrapped, but not crushed. We have no evidence from anything they wrote down that there was any crushing of this patient. There was no, and after the fact, we don't see any documentation that there was anything wrong with his legs other than maybe an ankle, complaining of an ankle pain, and you're not going to get rhabdomyolysis from a squeeze of the ankle. Otherwise, all ankle sprains would be at cardiac risk. So this is an example of where you need to evaluate the patient and put the findings of the patient into context with what you're thinking about. Then the second thing is if you say, okay, I'm worried about hyperkalemia, you have to follow the protocol. You can't do half a protocol, just like doing half a resuscitation. You can't do that. Then looking at this 12, you see, I'm surprised. They could have said, oh, I think maybe this guy's having a STEMI too, because you've got it. But then you look at it and it says a left bundle branch block. You can't deal with that. So that, and there's no concordance anyplace on this thing. And then you also look at the fact that you've got that this is really super big R waves. I mean, he's got criteria for LVH written all over this too, which you can't also really read in the presence of a left bundle branch block. And you can't read peak T waves well in the presence of either of the things I just talked about, which is hypertension and or LVH and left bundle branch block. So it's kind of an this gets back to the old thing. If it looks like a duck, walks like a duck, quacks like a duck, it's probably a duck. And this is not a duck. This has too many things missing to be a crush injury. And rhabdomyolysis with hyperkalemia.
Yeah, and I would add, just like you're saying, is that you're going to see T wave changes, not these negative deflections below the isoelectric line,
Right.
And you'll see widening of the QRS, but you still don't see hyperkalemia does not manifest with a negative deflection in the QRS below the isoelectric line. It ends up widening into sine waving
Right.
in asystole, so you wouldn't see these S waves.
Right.
Yeah, no,
so kudos for thinking about rhabdo and injury associated with entrapment, but this guy did not have any findings of entrapment after you got him out. He was just trapped.
pinned, maybe.
Crushed. He was pinned, but not crushed.
Yeah. No, exactly. And I mean, you're looking at big muscle groups, if that's like the thigh,
Exactly.
somebody who is pinned at the chest or the abdomen. An example would be like a pallet with a bunch of weight on it that's pinned him for a period of time, a longer period of time, not just
Or
immediate.
a piece of concrete like about the size of a Philadelphia barrier.
Those are good points.
Something big laying across a lot of muscle mass.
Yeah. Thank you for those points. Moving on to case 3. So I have a 43-year-old female, EMS was called for shortness of breath. PPE usage was appropriate. They found the patient to be unresponsive. Her airway was open, but she wasn't protecting, and she was in obvious respiratory distress, or as documented as respiratory effort was inadequate. They noted that her pulse was present, but it was weak and slow, and there was no signs of active bleeding. She was found on her bed, unresponsive. Initial vital signs notable for a heart rate of 36, a blood pressure of 146/127, a respiratory rate documented of 15, GCS of 3, and she is of average normal weight. The only past medical history is that she's an asthmatic, and that the family who were on scene but don't live with her had reported that she called them for shortness of breath. She has a history of asthma, and she uses her inhalers frequently. Prior to transporting agency's arrival, the patient was already on a non-rebreather. Vital signs, as I previously mentioned, and at 1 minute, pacing was initiated and set at a rate of 80. 2 minutes, an IV was attempted. At 3 minutes, the patient arrested. She was given 5 milligrams of albuterol. From my understanding, there was evidence of nebulizer, meter dose inhaler debris all around her room. So that was what prompted the bronchodilator initiation. At 5 minutes, they noted that she had wheezes. They continued CPR. A humeral IO was placed at 7 minutes. At 8 minutes, she was given her first dose of epi. She was switched over from bag valve mask to iGel, and they noted that there was marked difficulty with bagging her. At 13 minutes, she received her next dose of epi and additional 5 milligrams of albuterol. There were some secretions that they suctioned, and at 16 minutes, they attempted to intubate her, which was successful on the second attempt with direct laryngoscopy. At 18 minutes, they record their first SpO2 and end-tidal CO2, although it is noted from both crews that the SpO2 was not reading. It wasn't just not reading because of a less than 50 sat. They said that it was just not reading at all. Her SpO2 was 76. Her end-tidal CO2 was 98. She was given an additional milligram of epi. Her blood glucose was 113. At 23 minutes, she got her third dose of epi. At 26 minutes, online medical control was contacted, and they instructed them to give her bicarb. She got another 5 milligrams of albuterol. So at this point, she's gotten 15 milligrams of albuterol. She received 50 milligrams of bicarb, and ROSC was achieved at 31. Yep.
What's her
Initial
rhythm, and what's her rhythm at this point?
So they document that her cardiac arrest rhythm is asystole.
Okay.
They don't document what it was throughout the resuscitation, but there were strips in the chart. I know that there was waveforms, but I think it was the end-tidal CO2. I don't know, unless anyone on this call knows if she stayed asystole until she got ROSC or not. So at 31 minutes, ROSC was achieved, and that's, I believe the first arriving was only there for a few minutes before the transporting, so it was maybe 31 minutes of, from ROSC achievement from the transporting agency's time, and if you subtract out, so she was cardiac arrest for 29 minutes. At 33 minutes, vital signs were obtained. She had a heart rate of 100, blood pressure 63/26, respiratory rate bagging of 14, GCS of 3, end-tidal of 97. She was given her fourth time of albuterol, so 20 milligrams of albuterol at this point. End-tidal CO2 is 97, and she was started on an epi drip. 1280 kg, showing wide complex, but appears to be I'd probably call this AFib, as I don't see regular P waves. It looks like there's a left bundle branch block. Not anything else that I would say on this to report. I don't know if Dr. Whitwer would report anything else on that 12 lead.
That's what I would call it too.
Yeah. She went back into cardiac arrest at 36 minutes. She was given a milligram of epi. They got ROSC again, and they repeated her 12 lead at 41 minutes, which is the bottom one. I have both of them so you can kind of compare. It still looks AFib, agonal. She's got pretty, a lot more P wave or atrial activity compared to her QRS. It's slow. It's not RVR is my point. And then she's got this ST segment in her anteroseptal leads that they're reading as possible ST elevation. When compared to the previous EKG, it's more rounded than it was previous, and there's some potential ischemic changes noted in her precordial lateral leads with the ST depression. So at 45 minutes, her heart rate's 120. They notify the hospital of a cardiac arrest with ROSC. They initiate transport at 48 minutes. She rearrests en route to the hospital. It was a short transport time of 5 minutes, and they get to the hospital. So this case was brought up because it was an unfortunate situation that we have a young individual who I believe we could have identified earlier as being profound asthma exacerbation leading to respiratory failure, and that we can all learn from cases that we can improve our care and also recognize the other components that we need to be aware of. So anyways, the good PPE usage was appropriate, early vital sign obtainment, IV attempt, partial management of her reactive airway disease. She received albuterol and epi, and we'll say in this case, they gave the epi for the reactive airway disease, not for cardiac arrest only and hypotension, but for all components. They escalated to her airway management as they found difficulty with bagging her with the iGel. They contacted online medical control when they fell at, my understanding is they weren't calling online medical control to pronounce her. They were calling for guidance, and that they obtained a post-ROSC 12 lead, and they didn't initiate transport immediately after ROSC. Waited, she rested again, and then she got ROSC again. So this case is an example of recognizing a patient who's in peri-arrest as opposed to pacemaker failure, and that the most appropriate management would not be to pace them, but to initiate pre-cardiac arrest resuscitation or aggressive respiratory distress resuscitation. The importance of ventilation feedback, I assume, and it was confirmed that the patient was bagged with a BVM with the EMT. So the importance, especially in these high acuity patients, of all providers, even if they're not the paramedic on the scene. So the importance of all of our EMTs out there relating back to their team that there's difficulty with bagging this patient. In this particular instance, when I queried the crews, they said that the EMT bagging the patient had mentioned nothing about difficulty with ventilating this patient. So somebody that has asthma, assuming that there's a obstructive component going on, should be difficult to ventilate. They did not mention any difficulty with the bag valve mask component. I had asked, was there an air leak? And recognizing that although we pass on these procedures or these tasks to our EMT partners, that we still need to own and recognize if there's an air leak, check in with any EMT or paramedic, any difficulties, not just assuming that hearing nothing is good. And then, in speaking with these crews, they had mentioned that, yeah, we couldn't get an SpO2, but it didn't really matter because she was sick. I think that this SpO2 and end tidal would have been very helpful in helping determine that this patient was respiratory versus other reason for her to be bradycardic. And one of the crews had said that they had a sixth sense that this scene was not, it did not sit well as in like a typical straightforward. It was definitely like out of place, in that they were thinking other reasons for this patient to be in this extremis, such as like an overdose. So, or just bad luck in that she has some primary cardiac problem undiagnosed or unrelated, but from previous. But if getting an SpO2 early, or finding another life pack that was able to get an SpO2, seeing that her sats were in the 90s with a heart rate in the 30s, would make you think that it's not a respiratory issue. But seeing a sat less than 50 or in the 60s would definitely make you think twice about, is this pacemaker failure or is this bradycardia before asystole? And the same would go with the end-tidal CO2, would help you recognizing if they're inadequately ventilating or some type of acidosis, alkalosis.
Jackie, as I recall, you said that when they did place the iGel, whoever was managing the iGel said there's difficulty in bagging this patient. So I would surmise that there was probably difficulty at the beginning that was never recognized or never related.
And I spoke about that. They had told me that the ventilation with the bag valve mask went just fine. And it wasn't until the iGel, and I had asked, was it probably potentially the first time that we actually had good ventilation? And that's why I was asking for an air leak. They thought that there was something with the iGel possibly partially obstructing her tongue or something along those lines. So that's why they moved up to intubating her.
Mm-hmm. Did they get a CO2 off the iGel?
I don't think that they got the first end tidal was off of the ET tube, so no.
Okay.
So no. So in the emergency room, they were able to get ROSC. Chest X-ray showed a right infiltrate. Her gas was pretty poor. Her pH was 6.98. Remember, normal is very little fluctuance from 7.4. Her PCO2 was quite elevated at 88. Her bicarb was 20. Her lactate was almost 10. Her 12 lead showed sinus tachycardia. The ED team had added Solumedrol. They did not give her MAG. And they documented that they had profound difficulty with ventilating her, probably because of her profound lung mechanics from her reactive airway asthmatic disease. She got admitted to the ICU. They did targeted temperature, and after they warmed her, she had no response. She was off sedation. They got an MRI of her brain, showed significant agnoxic brain injury. Her family elected to make her an organ donor, and brain death was determined at hospital day 3, and she underwent organ donation on hospital day 4. So I'd like to talk a little bit about the things that are similar with COPD and asthma and the things that are different. And when you have that small percentage of profound asthmatic or COPD presentation, what to do so that if we have to move towards intubation, get some guidance about what to watch out for and what we should reach for. So in the unstable patient with reactive airway disease, we see in asthma that their condition is reactive and reversible. There's inflammation that leads to constriction, and there's mucus production. Early, it's wheezing and airflow obstruction. Again, that's from bronchial smooth muscle constriction and airway edema. And late, there's airflow obstruction and prolonged bronchospasm, and that comes from increased airway mucus production and bronchial smooth muscle spasms, which is kind of indicated here with this image on the upper right. With COPD, this is a progressive disease. It's a fixed obstruction with loss of elastic recoil of the lung tissue, causing resting and dynamic lung hyperinflation. And it's not fully reversible. And it's associated with abnormal chronic inflammation. So kind of indicated here on the bottom right. Management for reactive airway. So I group it into asthma and COPD. Asthma is going to be reversal of the acute airflow obstruction, and that's the mainstay of the bronchodilators, the steroids, the bronchodilator steroids, and reversing that condition, and then epi as well. But I'll talk about that in a second. And then COPD is really recognizing and supporting the impaired ventilation. So early CPAP. Early CPAP. CPAP's not super helpful for asthma. Couldn't hurt, but it should not be your first line. So CPAP for your COPDers, epi for both asthma or COPD if they're extremist to the point that you think that they're near arrest, and MAG is consideration. 2% of these patients are going to be profoundly sick enough to be intubated. That's not a lot. So the majority, you should not have to come down this route unless you're one of the unlucky or lucky, I guess, however you want to say. So before intubation, once that decision is made, because you should not be waiting until they respiratory arrest, is to stabilize their hemodynamics. Both asthma and COPD are at potential risk or likely risk of hypotension. That's because they really aren't drinking or hydrating when they're having their respiratory distress or preceding their respiratory distress. They're increasing their ventilation, which leads to insensible losses for water. In that our meds are going to potentially make them even more hypotensive. So giving them some IV fluids, and as long as they are not in heart failure or you don't suspect heart failure associated, is increasing the chances of their blood pressure to improve, and having a low threshold to support them with pressors if necessary before intubation. In use of meds for RSI, you should be really looking for ketamine and succinylcholine. Ketamine because of the bronchodilator and broncho smooth muscle components. And then in our COPD patients, we should be really focusing on reaching for etomidate over ketamine, as etomidate has less cardiac arrhythmia predilection than ketamine, and our COPDers tend to have concomitant cardiac disease. For both, if you are intubating these patients and you're ventilating them and you have the luxury of having a ventilator, but even if you don't, there's some components that you should be also aware of and aiming for. So both our asthmatics and COPDers, we're aiming for a low tidal volume. We're really decreasing their rate so that we allow for permissive hypercapnia. So really, they should tolerate end-tidals in the 80s, because we're not trying to bag them as fast as they had previously been breathing, because we want to allow for them to have adequate exhalation. So shorter inspiratory time, longer expiratory time, and low minute volumes. And then we're really trying to aim for low PEEPs, so 2 to 5 centimeters of water. We're looking for ventilator synchrony. So in our asthmatics, it's going to be really important, especially to have them appropriately sedated. So making sure that we are recognizing if we haven't met our goals in post-intubation sedation, more so with asthmatics than COPDers, and really only looking at paralytics if we feel that we have actually adequately sedated them. Paralytics should not be an early adjunct to their ventilator desynchrony management. Let's see what else. COPDers tend to not need as much sedation. And then you're really being cognizant about barotrauma, either because of their underlying pathophysiology or because of your ventilations. So if you find that the patient's desatting, they are persistently agitated despite appropriate sedation, or they have, if you have a ventilator that alarms high peak pressures, you should be looking and identifying for signs of pneumothorax and management of that. So in our protocols, looking at our respiratory distress protocol, kind of focusing here under B and C, but in this patient, B, albuterol atrovent is recommended, solumedrol, epi for patients that are in status asthmaticus, and magnesium. And then consider Cpap. So it's already indicated that it's not the mainstay for asthma management in COPDers. Recognizing the patient, if they're cyanotic or suspected MI or severe respiratory distress, you're using high flow oxygen, be prepared to assist respirations. And that first part of assisting would include Cpap and then also working on some of the inflammation, but it's not the mainstay of management of COPDers. Any questions, thoughts? Here in our notes and precautions, aggressive airway management, including early intubation, is appropriate for the patient who does not respond to treatment or is rapidly deteriorating. Hyperventilation may be a response to an underlying medical problem and should only be considered after these other causes have been excluded. Do not treat hyperventilation by rebreathing CO2. Dr. Whitwer, you have any more comments for that one?
I think you've covered all of it. This was another case that when I looked at it, I said, okay, looks like a duck, walks like a duck, talks like a duck. It's not a seagull then. And
Yeah.
so if you get a patient who, and as I recall also this patient, the patient is, she called her family, said, I'm short of breath. I don't think she called 911. I think the family did it.
Yeah.
So, so this is an asthmatic and we knew when we walked in the door, this was an asthmatic. And then finding all the paraphernalia for asthma laying around the place, that's a good hint. And then you find a person who's having difficulty breathing or who's bradycardic and bradypneic at that point, and you think, oh, this must be a cardiac problem. No, this has to be, this has to be what it is. It's asthma. There's a whole thing in philosophy of science. Very simple thing to remember is that the least number of assumptions that you make to get to the answer, you're going to be more correct. So if you say, oh, patient's an asthmatic, she looks like she's almost ready to arrest. I think she's having a heart attack. You're making too many assumptions. You say she's an asthmatic, she wasn't breathing, she was sucking her inhalers, and she got low O2, and she has what happens when people have low O2, they ultimately become bradycardic and go to an arrest. Otherwise, every time we resuscitate a newborn infant who, when they brady down, we know that they're bradying down because of low O2. We don't put a pacemaker on the babies. We treat their O2.
Yeah, it applies to both adults and pediatrics. Respiratory distress, hypoxia. If you're finding that your rate is starting to normalize, the heart rate is starting to normalize, and you're starting to become bradycardic, prepare for arrest.
Yep.
Yeah, it's an unfortunate case. I'm not saying that if it was recognized immediately as it was, and even if aggressive early epi, and this is an example that I would, if you can't get access and you don't have access, just give epi IM, start that early to help turn this around for this patient. Even if all things were recognized immediately, We're not saying that this patient would have had a different outcome, but we would have known that we had identified and managed aggressively, giving her the best odds for resuscitation.
If you have a severe anaphylactic, you don't wait till you get your IV and to give the first dose of epi. You give a dose of epi IM, and then you start doing. Then you start getting your IV.
Absolutely. We had just talked about this with the physician group at Peace Health, is that most of the data on poor outcomes in anaphylactic, this was not an anaphylactic patient, this was an asthmatic, but is delay in getting epi. So it's the important component, as long as there's no contraindication, to manage these patients, especially if we see them as profound in our history of respiratory distress. If we're seeing someone who looks profoundly poor, maybe not near rest at this point, but profoundly poor, I would be considering aggressive management, not just starting a little bit of albuterol here. All right, thank you for that, Dr. Whitwer. So our last case is of a 50-year-old. The dispatch information is that she's unconscious. PPE usage is appropriate. They found the patient to be awake, ANO times 4. She had an open airway and she was protecting. They noted that her skin was pale, warm, dry, and that she was awake but lethargic. Vital signs were obtained within the first 9 minutes. They noted that she was bradycardic at 54. Her heart rate, or her blood pressure, was trying to match it at 49/26. Her respiratory rate of 11. Actually, let me rephrase this. So she was awake initially, and as they were moving the patient, she became unresponsive. So this set of vital signs is after she became unresponsive. So her heart rate is 54, her blood pressure is 49/26, her respiratory rate is 11, and her GCS is 3. She appeared to be very orthostatic, in that as soon as they attempted to move her, she passed out. The past medical history was cardiac, but there wasn't anything specific about her cardiac history that was documented. They also noted that she has a history of pancreatitis. The history provided by bystanders, I believe her family, was that 12 hours earlier she had fallen when she stood up, and that they stated that she was going in and out of consciousness throughout the day. The patient states that she did not lose consciousness, but she did strike her head. She had no neck or back pain, and that she had recently been admitted for pancreatitis but left against medical advice, and that she was discharged with a Holter monitor, which was present upon EMS's arrival for some kind of tachybrady problem. Prior to arrival, the first responding agency had got a glucose of 106, and they did a LAM score, which was normal or not high. And that the first thing that the transporting agency did was get a 12 lead within 6 minutes. Looks like sinus, narrow complex, looks like physiologic left axis deviation, no ST changes, and normal, maybe a little delayed airway progression, and then normal QRS interval and prolonged QT based off of the QTC on there. They obtained an IV and they gave her 10 mLs of fluid, which initially, assuming that they didn't know she was hypotensive yet. After she became unresponsive, they initiated transport and they started her on an epi drip because of her profound hypotension at 4 mics a minute. At 15 minutes, her heart rate's 78, her blood pressure is 65/23, her respiratory rate's 14, she's still unresponsive. Her SpO2 is 95, her end tidal is 21, and they give her additional 150 mLs of normal saline in conjunction with her epi. At 16 minutes, they give her 0.5 milligram of Narcan. And at 19 minutes, they get another set of vital signs noting that she's still not tachycardic. Her blood pressure is a little bit improved compared to her 9-minute one at 69/34. Her respiratory rate is still adequate at 13. Her GCS now is 15, and her SpO2 and end tidal are largely unchanged from the previous. They repeat her 12 lead, which at this point is lots of artifact, poor tracing, narrow complex. Can't tell if there's necessarily P waves anymore, but probably it's just probably quality of this EKG. And she's in normal sinus. There's some T wave inversion in her septal leads and in her lateral, but not quite a STEMI. And I don't see any other concerning arrhythmia at this point. More just continue to monitor and maybe get a better 12 lead. They get to the hospital at 30 minutes. So 12 lead within 10 minutes, they thought about differential diagnoses for her altered mental status, although I think that her pressure was probably the biggest culprit for her altered mental status. They placed 2 IVs. They did initiate pressors to try to improve her blood pressure. They got serial vital signs and they went code 3 to the hospital. The bad is that in the time to do the epi drip, I think that we could have put her on a pressure bag and given her more fluids than 160 mLs of normal saline, making sure that we have the tank full prior to aggressively managing the vasoconstriction component of the pressors. And then for this patient, I did not say anything about, well, it would have been fine anyway if we weren't counting the first in for trauma having, but considering, is this patient a medical patient or is this patient a trauma patient? It sounds like, although she had fallen and hit her head, that she doesn't necessarily look like a intracranial bleed in that regards. We would expect to see like Cushing's with bradycardia and hypertension, not hypotension bradycardia. So it's probably some kind of medical issue, and that having appropriate time to resuscitate a medical patient would be adequate. You don't necessarily need to load and go if we haven't been able to complete all the things that we would want to do for the patient.
Jackie, you document that they did a lamb score. Did they do a BFAST beforehand?
Assuming that they did, but they didn't document it.
Mm-hmm. You generally don't. You have to have a positive BFAST before you bother to do a lamb score.
Yes. Yes. So in the emergency room, she went to, yeah, this is the one I missed up on the first case. But anyway, she went to Legacy Salmon Creek. She had a history of alcohol abuse in that she was admitted previously for alcohol-induced pancreatitis, in that they assumed that her PO intake was poor as she chose alcohol over hydration and other nutritional factors. Her heart rate in the emergency room was 44. Her blood pressure was 44/33. They got a 12 lead. They initiated shock resuscitation with adequate IV fluid resuscitation, as well as norepi as the pressor of choice. They placed a central line. She had an elevated troponin. And she had an elevated creatinine concerning for an NSTEMI and renal failure. She had a chest x-ray that was unrevealing, and because she hit her head, she had a CT of her head, which was also read as normal. They consulted cardiology in the emergency room, and because she had an elevated troponin and concern for what they thought would be cardiogenic shock with her blood pressure being so low, they recommended transferring her to a catheter cardiac catheter capable hospital. So they transferred her to Good Samaritan from the ER. After she was transferred, she was admitted to the ICU for hypertension and bradycardia, and what they had ultimately decided was a type 2 MI, so a demand ischemia. They did an echo, noted that her ejection fraction was actually not low. It was elevated at 65/70, and there was no areas of her heart that appeared to have wall motion abnormalities. They discharged her on hospital day 4, and they believe that all of this was related to the tizanidine. So this was a case brought to me by Eric. Thank you for referring this one. Tizanidine or Xanaflex is given for a couple different conditions, but most likely they're prescribed for spasticity. And that's like for like your ALS or your spinal cord injury individual. Some off-label indications would be migraine, seizures, and insomnia. It works as a alpha-2 receptor agonist, and it inhibits the excitatory amino acids, which allows for inhibition of motor neurons. It's metabolized by the liver, and it's excreted mostly out of the urine and less so from the feces. There's another 20% that I didn't find where it was excreted, but liver metabolizes it, urine gets rid of it. Important because this patient has impaired likely hepatic metabolism because of her alcohol abuse, and she was identified to be in renal failure, which also meant that she wasn't excreting things normally. So adverse reactions with tizanidine, most common is going to be drowsiness, hallucinations, dizziness, weakness, nervousness, runny nose, blurred vision, constipation, kind of like your run-of-the-mill potential side effects. But severe would be anaphylaxis, QT prolongation, which if you remember in her 12 EKG, it indicated there was a prolongation. It could also lead to bradycardia, profound hypotension, Stevens-Johnson syndrome, and can also lead to hepatotoxicity. If these patients are prescribed tizanidine, they lose it or decide to stop taking it, they can have rebound effects, which can include hypertension, tachycardia, and increased spasticity. So interesting case of tizanidine. They noted that they held a tizanidine during that hospitalization for a period of time and her vital signs improved. They weren't for sure if it was tizanidine. They added it back and she immediately became hypotensive again. So she now has an anaphylaxis indication in her record towards tizanidine. So another time we're going to talk about shock in our protocol where this patient would be fall under. So this patient would be concerned for hypovolemia, likely as or cardiogenic shock. But at that point, the cardiogenic wasn't identified as a potential until her troponins came back. But control external bleeding, make sure that you are guiding your resuscitation for a MAP of greater than 65 and watching for signs of volume overload, as well as improvement in mental status and giving up to 2 liters of isotonic fluid. If they're not responding to that, considering a pressor, either norepi or epi. And yeah, and if you think they're in cardiogenic shock, you're going to be a little bit more careful about resuscitation volume, but you will give some fluids, you'll reassess, watch for decompensated heart failure, and give pressors as appropriate. Dr. Whitwer or anybody?
Interesting case.
Yeah.
But you know, you wouldn't expect, and you know, we're not expecting the medics to come up. I mean, it took a long time for them for the experts to fall to, to figure this out. But we still treat shock the same way.
Yeah.
For EMS.
Yeah, and she was interesting because she was never tachycardic, which it'd make me want to look to see what rate controlling meds is she also on. But yeah, treating shock with appropriate fluids, maybe more aggressive if you didn't think there was cardiogenic shock involved or not, and if you feel like you've adequately fluid resuscitated, pressors.
And particularly with the history of pancreatitis, she's likely to be fluid depleted.
Yes.
Yeah.
Absolutely. So in review, multiple things can cause cirrhosis. Alcohol can also cause cirrhosis, recognizing that you don't have to wait to see a patient like this, protuberant, umbilical hernia, umbilical vein pronouncement, and jaundice. These patients can have significant sequela without the end stage liver disease presentation. And then for your traumatic rhabdo consideration, you're really looking at appropriately hydrating them, but recognizing that if you're thinking trauma, that we talk about permissive hypotension. So balancing that or contacting medical control for guidance in that, recognizing hyperkalemia as what it should in EKGs, and recognizing when EKG findings are not consistent with hyperkalemia in conjunction with the physical exam, and making sure that if you are moving down a pathway of management, you're covering all management unless there's some particular contraindication to doing so. In your respiratory failure, but specifically your asthmatic respiratory failure, recognizing the scale of that patient's presentation and appropriate interventions that would help the patient. So remembering that you're going to be managing potential hypotension or already present hypotension prior to RSI, if at any bit possible. I'd say fluids, and then push dose. To me, push dose is fast. If you can put a epi drip together faster than push dose, then do that. Make sure that their blood pressure is adequate before moving towards resuscitation, using ketamine as the agent of choice for your sedation in your asthmatics, and etomidate as your agent of choice for your COPD respiratory failures, and recognizing appropriate ventilator management for these type of patients, and that hypotension should be considered possible, and hypotension should go down the shock algorithm, and recognizing that tizanidine, Xanaflex may be a culprit, but we wouldn't necessarily do anything in the pre-hospital setting other than making sure that they didn't get their dose before they left home.
I just looked up the frequency of adverse effects with tizanidine, and it's not
rare.
It's rare, but bradycardia, hypotension, orthostatic hypotension is definitely reported with it.
Mm-hmm. Yeah, well, thank you guys for your time and attention. If anybody has any questions, feel free to say it now in the chat, in the email. And then Dr. Mock, how did you want to do feedback? I know we talked about that. I don't know if we ended up clarifying. We're going to do it in Target Solutions?
We'll get back to you on that. And
Okay.
for today, email any feedback you have on the presentation, and we'll work on a smoother solution.
All right, well, thank you guys. And I guess I'll stay on this just in case if the MPD, if we want to stay on this or if we want to go to the other.
Because we're recording this, let's start over again.
Okay, sounds good.
Okay.